Hi, everyone. Good afternoon. We hope to make this interesting, and just to make sure it's interesting, we're going to need some audience participation after we get through the first set of questions that I'm going to ask the panelists. So we're going to try to leave about 15 or 20 minutes to make it more interactive with all of you, because many of us have been in your seat, and you end up getting more out of these particular panels when you've got a chance to ask your question of the panelists. So we'll make sure we have time for that. So I'm going to start with the first introduction, the furthest away from me, which is Dipti Patel Misra, Chief Data and Analytics Officer at CEP America. Next is Dr. Todd Ferris, CTO of Stanford University School of Medicine. Next to Todd is Chuck Podesta, CIO of UC Irvine Health. And finally, next to me is Sajid Ahmed, Chief Informatics and Information Officer at Martin Luther King Jr. Community Hospital down in SoCal. So I'm going to start it off with a question for each of the panelists, and I'm going to start with you, Dipti, and we'll just come back towards me, which is, tell us the innovation that you've been working on in the last year or working on right now that's been most interesting for you.
Perfect. Thank you, Bob, and thank you for having me on the panel. So in terms of innovation, let's talk through, some of the healthcare transformation that has happened, right? So in some time ago, it was data and batch process retrospective 1 month, and then let's do the EMR. Folks thought really, let's get the EMR data in, and guess what's going to happen? It's going to solve all of our problem of going into the value-based healthcare model, improve outcomes. And I'm going to ask a show of hands here to see how many of you have actually seen that. With the billions of dollars spent in the EMR, has really outcomes improved? So right there is our innovation, actually. Right? So the innovation that we're working on truly is, what do we need to do with data and analytics to actually make it impactful so that we can meet the triple aim? So our goal truly is to find the real-time decision support tool. So recognize I'm not calling it alert, because our physicians here are truly, in an alert fatigue mode. We're really trying to find things that they can use. And you'd say, what is different about you compared to everyone else? We're the only data-led physician practice management group. So our data and analytics that we build is actually built by physicians for physicians, such that they can actually change what needs to be done to improve outcome for just all of us. Because I put this in the fact that we forget sometimes that we are patients. Right? We make data as a third-party entity there. It's for somebody else. It's not for me. But data and analytics, truly, in the right hands of our physicians, actually will make the impact that we're all looking for. Thank you, Bob.
So I'm maybe a little bit more of a CTO bend on this for things that we've been dealing with, and that's specifically the cloud. We've been trying to really understand how that. And with partners like Missy there, Box, we've been trying to address real fundamental, seemingly simple things like file sharing, and try to take that across an enterprise which isn't uniform. An academic medical center just typically is not your classic top-down organization. We have lots of people doing lots of different things, so sharing files is actually tricky. The next thing, and so that's one we've kind of dealt with, I would say, mostly. And where we're going now is, how do we take that same learning to the researchers? Researchers spend an inordinate amount of time trying to bring up an infrastructure. They have an idea. They want to just go do research. They don't want to spend time setting up a server, getting it secure. How do I move data from point A to point B without? So we're trying to build out that whole infrastructure in the cloud so they can just go, and they have it. They don't need to go and spend 2 months setting it up, which is currently what we're having to deal with, or 6 months or longer. So that's where we're headed.
At UC Irvine Health, we're actually been at it for a little while, but we're building an analytics ecosystem. I like to call it ecosystem because I visualize something that's growing and breathing and changing, every moment of the day, as opposed to some sort of black box that you just dump your information into and then try to get it out. We're basing it on just capturing sensor or source information wherever it may be at any given time in its native form without the mapping and everything that you see in a SQL type of environment. It's based on Hadoop. And just a quick example of what we're doing right now, we've captured about 4 years of all of our monitoring equipment data, and we take it in 1-minute intervals. So we're actually going back now, we call it our Code Blue analysis, which we're looking at all the patients that crashed based on, various issues that they had, and then backing up the clock by, 30 minutes, an hour, and looking at what was going on with those particular patients, a half hour or an hour before they crashed, and trying to put some algorithms in effect where we can maybe use that in a predictive way or a suggestive way to physicians going forward. So if there's something similar that we can then alert the physician, an hour, a half hour before the patient crashes as opposed to when it actually happens. So we're rolling that out now. We're getting some promising looks at it. Some of our researchers are very interested in it as well.
Awesome. So I have the benefit of having been part of a startup hospital that just went live about 12 months ago. So I can just quickly name a couple of things that we started to innovate on or think differently about because we had a unique opportunity. We had no doctors, no nurses, no patients prior history. So we went full technology, you can imagine, but technology is only one aspect of it. It's really the business and the workflow, the clinical workflow, the patient care that we focused on. To support that, a couple of things we looked at. First, I got the wonderful opportunity to ban all fax machines inside the hospital. How many of you guys have fax machines still? Raise your hand if you still have fax machines that I banned them all. As we hired people, they actually got angry at me. They said, "Where's the fax machine?" Obviously, we use electronic faxes and nothing truly technologically innovative, but just getting people to get into a workflow of using and receiving to prevent HIPAA violations and all that, a better workflow. I still in disbelief as we hire people on, they go, "Where's the fax machine?" They've secretly tried to buy fax machines and install them. Anyway. But another opportunity we did that we've successfully done is we introduced mobility from the ground up. We actually worked with Cerner, which is our EHR, and we're a beta partner, launched full mobility with all the doctors. So all the doctors, nurses, EVS, security, administration, we're all connected inside the hospital on an iPhone or an Android. Nurses have access to patient information. They get alerts of the patients that they're assigned to. Doctors and nurses share information. They use it for VoIP calling, et cetera. But the number one use that we've seen is texting. Texting is the biggest use within the hospital system. So that's something we've launched and are showcasing. And one more thing I'd like to mention that as we're now fully up and running and been open for a year now working with partners is we're using telehealth, e-consult to really communicate between providers and our specialists prior to the patients coming into the hospital, which seems awkward because many hospitals are still volume-based. And as part of that, the really cool innovation as a brand new hospital that we're working on doesn't involve necessarily technology. It's about setting up the hospital for value-based. Now we're purely Medi-Cal. We're like 89, 90% Medi-Cal, 8-9% Medicare. And Medicare's and CMS isn't supporting value-based payments on the Medi-Cal side. So we're trying to set the foundation for that, and that's the biggest innovation we're working on.
Great. So that's a great cross-section and a diverse set of innovations each of our panelists is working on. But also in their roles, they get to take a look at the entire technology investment landscape for their organizations. And the next question is related to that, which is where is the majority of those investment dollars, meaning the dollars, capital or cash that is attached from a planning perspective to technology in their enterprise, where is that spend going? So I'm going to start with you, Todd, this time, if that's okay.
Sure. For us, the majority of dollars has been in security. I think that probably many of us have felt that recently, and it's unfortunate that it took us this long to get there and make the realization that we needed to be investing more in that space. And, we've always had policies and procedures requiring security, but what we've realized is without technical teeth and locks, that sometimes people don't follow those policies and procedures. And so we spent a ton of effort over the last 3-4 years just investing in that, making sure we have consistency across our enterprise, bringing in vendors like Box and others to help us with that to achieve security.
Sure. With us, it's security definitely, but Todd already handled that one. But for us, it's real population health. Before UC Irvine, I came from Vermont, the University of Vermont Medical Center, and if you know Vermont, we were trying to do single payer up there, and that's even taking ACOs to the nth degree. And so when I came out to California, I was surprised that from a value-based care perspective, Obamacare and ACOs really hadn't hit this area that much, and but now that's changing rapidly. So in our strategic meetings that we're having and discussions, it's really about how can we flip the switch to value-based care, because now the payers are starting to, the 6 to 8% increases they were given year in, year out are gone. It's zero, or now they're talking about negative, and it's all going to be based on value-based care and quality and cost. So it's what I'm familiar with from coming from Vermont, so I'm happy to see it finally hitting California, although it's going to be a real struggle for us. So from an IT perspective, there's a lot of parts and pieces to that, from the analytics side, from a health information exchange strategy, the ambulatory physician primary care practice, EHR, which is some of the things you need to do there, patient portals, patient engagement. It's a whole different ballgame. And the CIOs really, when you're in that type of atmosphere, in that type of model, going from fee-for-service, the CIOs really have to step up their game, because it's not just electronic health record implementation anymore.
Almost the same as Chuck. It's security, it's training all your population, and even for us as a standalone hospital, those have been some of the big expenditures we've made early on in building up the hospital. And actually, we're moving towards investing in data analytics, population health management, and that's where a lot of the business focus of the hospital is. And we're in a unique situation. We're in an underserved area of 1.3 million people where there's only one other hospital. And for our size of hospital, we see about it's annualized at 70,000 visits through our ED for a 130-bed hospital. So for us, population health management is a key factor. So that's where we're putting a lot of our efforts into.
Dipti?
So for our end, I'm going to separate it out in 2 buckets. I agree with all of the panelists here. Part of our dollars is really going into foundational elements. I think, as we've grown and as healthcare has transformed, we've recognized that we need our foundation layer to be really built in such a way that it can sustain long-term growth. But a majority of our innovation, actually, dollars-wise, is going into futuristic thinking. What would we need to have happen? What are some of the things we should do and do rapidly, such that even if we fail, let's learn from that failure and make it happen. So a lot of our focus in those terms, and yes to population health, yes to data, but so what? I could do a lot of things with data, but if it can't be used at the right time, with the right person, for the right reason, then it's useless data and information. So sort of that's how we've straddled both ends.
So you heard security, you heard population health and analytics, and with Dipti's comment, it's just not getting the information, it's actually how you use it. And can you actually showcase how you're using it for improved outcomes? The third question is really about obstacles you're facing in either technology planning or technology implementation. So Chuck, I'm going to start this round with you around just what are the major obstacles? You secure the funding for these different investments, you're excited about working on it, but what are the major obstacles your organization runs into?
Sure. Well, if I take the population health example and all the technologies that you need to kind of knit together, you can't go out and buy Epic for population health. and you can't buy Cerner for population health. You can't, pick your EHR of choice. They're all trying to get there. Epic has Healthy Planet and some other tools that they've come out with. Cerner does as well. Some of them look fairly promising, but they're not mature yet. So to just go out and be able to pick a vendor and say, this is our population health vendor, it doesn't exist. You've got the analytics component as well. There's a lot of different players in that space. Some of them on very old technology that will box you in, others that are newer technologies but unproven yet. So the obstacles to me is how do you knit that together in such a way that, from a physician standpoint, and Todd can talk about that more than I can, that it's something that they can use and adopt. And then how do you get that technology to the desktop in, say, a private primary care physician's practice, because they're the gatekeeper for the patient. So how do you get that through their electronic health record in a way that it's actionable to them, and they're not signing on to 4 or 5 different systems to try to use the information that you've gathered for them. And that's a real challenge, especially with some of these EHR systems that aren't quite as open as others are at this point.
And then I'm going to ask each panelist, as soon as they bring up the obstacle, if they could also talk about how they're trying to overcome that obstacle. So as a follow-on question, how are you attempting to overcome that challenge?
Just going at it one step at a time. I think, a lot of CIOs that I've talked to out there, though, on the analytics side, they'll buy a large system, and because their CEO says we need population health analytics, so they'll go out and do an RFP and then pick somebody and check the box and say, we've just solved that problem. And then 2 years later, they find out that it didn't do all the things that they wanted to do, and they just spent multi-million dollars to get nowhere. So I think it's an incremental approach that we're taking, and you just can't go out and spend massive amounts of money because I think, one, you'll fail, and two, as a CIO, you'd be, dusting off your resume pretty quick. Yep.
And we do know the average length of tenure for the average CIO, so you've got to make smart decisions. So, Sajid, how about you?
I plan to break that average length of CIO, length of stay. It's really the similar challenge, but a different context. We have a very underserved population, and so our context is 2/3 are at or below the poverty line. We're in a medically underserved area and a professionally underserved area. Even attempting to do population health or analytics on population health, the very first barrier we're encountering is the IPAs, the Independent Physician Associations, the medical groups in our area. They're Medi-Cal providers. They're working on margin. You could offer them free computers, free printers, which I've done, and they'll say, no, we can't take that printer because the toner costs too much and we can't afford it. So trying to even work with the IPAs as an organization to say, look, we're seeing your patients. We'd like to get the information from whatever system you're on, NextGen, Allscripts, if they're on a system, Office Ally, which is a $100 per month subscription system, and say, look, we'd like to get information on your patient before they come to the hospital, when they come to our ED, and likewise, we'd like to alert you. So our biggest barrier is, you think data sharing is one, and I don't want to say Health Information Exchange or HIA, but just data sharing, if we even solve that technical barrier, the number one challenge we have is, do they have the support to manage the workflow? So when our hospital, the ED, in a very simple example, sends out an alert or a notice or an email saying, hey, we're seeing your patient, or hey, it's 2 days later, we're going to discharge your patient, we're planning a visit, there's follow-up, here's some meds, just to even get that care coordination to be able to support real population health in our area, that's the challenge. And the only way we're overcoming it is almost step by step, we're doing it one IPA at a time, we're investing, that's where a lot of our dollars are going into investing these Medi-Cal providers and saying, look, we're going to support you. We're going to build out that interface. We're going to provide some support for your staff or get some staff at the IPA level to help coordinate care. That's our basic challenge for us in our area to even get into population health management. But we feel if we can solve it, and with Medicaid expansion throughout the country, this is a real challenge. So that's the number one barrier we're facing.
Yeah, so I like the example of the discharge, and if you know the primary care physician, you want to inform them. Is the strategy a single app, or is it, you mentioned interfaces, is it, we will interface into your system any way you'd like us to?
You know, it comes in various solutions. I like what UCLA did. They used Salesforce, I think, as a single API. I think if that can be done, if you're a big enough institution, I think there's tools and technologies, mobile technologies that can be used. We're actually looking at an integration engine. Actually, we launched eConsult, or I shouldn't say we. When I was at LA Care, I came from a provider, a payer side. I helped launch eConsult, which is a very simple tool, nothing fancy, just for primary care docs to talk to specialists as part of the referral process. So we're using now that same tool to connect our hospital specialists and our hospital staff with the referral coordinators and the referral specialists at the doctor's office.
So
we're
it
looking at
is an
stuff like
app
that.
solution as much as it is
App
an
and
integration.
application, yeah. But
Great.
again, workflow and staff need to be there at the other end.
Yep.
In an integrated system, you could probably manage it and massage it, but for standalones,
Yep.
which there's a few of us still left, it's hard.
Great. Okay, Dipti?
So from our end, similar to what some of my panelists have talked about, data use, of course, is an issue, technology is an issue, but for us, what is an issue, as you've heard me say, we're really trying to be on the leading edge, and you've got to find the right partner, right? If someone, still is struggling to do an Epic implementation, and I come in and say, I want to do real-time decision support, they're not ready to listen, right? Because they're in a different space. So for us, those are some of our hurdles, but at the same time, our biggest one is most of the providers, and I'll ask a show of hands, how many of you are actually at a hospital system? Okay, so most of you have probably heard me say this, right, or heard that your IT department is maxed out, right? So here I am, CEP doesn't own most of the data, and we're coming in and saying, we'd like to do this innovative thing, and they look at us and say, really, are you. So that's sort of our big hurdle, and I'll answer the second part of the question in terms of what are we doing. So we've actually been very fortunate. We worked with Freed Associates, helped us actually put together a plan that is implementable, right? We can all have a plan on paper that looks really nice, and we really targeted some of our providers, hospitals that are innovative, that actually would partner with us and be willing to hear us out, put together a plan, and very much are on plan, on target. And most of the times, as we go in and have the conversations, they're very relieved to hear that we will actually take on the ownership of some of the things that the IT department doesn't have to do. So I know, if you were to ask the CTO, CIOs, they'd say, oh yes, as long as someone else can do it, sounds like a great project, make it happen. So that's sort of the approach we've taken.
So I'm going to take a slightly different tact. For us, regulatory. Regulatory has been challenging. On the clinical research side, we have to apply the same huge regulatory apparatus that we apply for an entire hospital to a 50-person trial. And that's a huge burden for the investigators to have to get through all those regulatory hurdles. And it slows things down. It slows down the innovation that they can do. And so we're always looking for ways to help them, but the regulations are the regulations. We can't, break the law.
Todd, can you give us just an example of what a research team's trying to do and the type of regulatory issue?
IRB versus full trial.
Well, so some of it can be that. I think the bigger one that has really hindered us is the BAA, the Business Associate Agreements. So we have a lot of folks that would like to engage with startups or other companies to really fast innovation, and they really can't get the necessary terms in place. Maybe that company just doesn't have the level of insurance required. Just big regulatory hurdles to get those things through. So we're trying to be innovative. I wish I could say there's a great solution there. There isn't. It's we do work with our partners on the Hill to try and push and lobby. I do encourage anyone who comes across there's comment periods. Make sure you comment on upcoming legislation. In fact, the FDA just released, I think it was last week, a comment on EHR and clinical trials, and they're looking for feedback. So I always encourage people, make sure you give feedback on that. And then we try to be innovative. We try to, for instance, for some of our apps, we launched the My Heart Counts a couple years ago with Apple, and for that project, we actually moved that whole organization outside of the HIPAA-covered entity, and just to be innovative there, because it's not working with identified data, it's not part of our health system, they're not providing treatment, so we just moved them out. So that took off some of that regulatory burden. Be innovative. That's how we're trying to deal with it.
You had to create a whole new organizational structure.
Correct.
Outside of the parent organization.
Yes.
To deal with that.
Yeah.
Great. All right, well, you've got a distinguished group of analytics, informatics, and chief information officers up here. Now I'm going to turn it over to the audience for the kind of questions you'd like to hear some answers to.
I'm Chandra. I'm actually an entrepreneur. We have deployments at UC Davis, UCLA, and others. The question I have for the C-level, CXO people is, we go into various hospitals. You are considered the biggest hurdle who always says no. When are you going to change that perception? I'm a computer science IT guy myself, so I'm on your side. But when do you plan to change that perception?
Todd?
Is IT being the barrier to the kind of innovations you want to make?
It's the biggest barrier for us right now. Whether you go to Mount Sinai, you go to Veterans Affairs, you go to UC Davis, UCLA, UC Irvine, any large hospital group you go to, we get physicians to adopt it right away. You go to IT, everything comes to a stall. When is that going to change?
Yeah, so it's somewhat related to Dipti's comment around anytime you're asking them, there's so much capacity and so many demands on them, they're trying through their planning process to just identify what the right set of prioritization is. But I'm going to let some of our panelists sort of talk about, how do you change the perception of IT when, they're trying to get a lot of things done, they're a critical enabler of all this new innovation, and how do you overcome that constraint or that sense of the perception that IT can't be a great business partner?
Well, it seems like I got called out on that, so I'll take first crack at it. And I think that, to be fair, we do say no. And in fact, yesterday there was, I'm blanking on the person's name, specifically said I think it was yesterday's keynote, that they specifically say no or yes. And in order to sort of short circuit that rather than saying maybe come back and talk to us in 6 months, because that is frustrating. I understand that. But the reality is an organization only has so much bandwidth. And I think increasingly organizations are trying to set aside some bandwidth for innovation projects, but they have to focus those. They have to choose. And we do often feel like we're peppered by the clinicians who are out there saying, hey, I just saw my friend and he had this great thing and why don't you come take a look at it? And we're like, but we've got this list of innovative things we're working on right now. No, sorry. So it's challenging, and I think that one of the things is to ensure that we're coming to things like this and hearing about the next generation, making sure we're getting it into our queue, and then be there and be ready when we do the request for proposals to join in.
Yeah, I think part of the problem is, there's ways to partner with the CIO in that you can get to the CIO first, rather than, I want to be the first call you make, not the fifth. Because if I'm the fifth call, I probably can't help you. But now you've got my whole physician community all jacked up over a new type of technology. You make it even harder for me at that point, right? So I think what you have to do is figure out a way to partner with the CIO first, then go back out to the physician community, and the CIO can help you, navigate those waters to get the physicians involved. Because we're all in the same, we all want to, improve healthcare for our physicians and for our patients specifically, and make it easier on our clinicians to get their job done. So the forward-thinking CIOs, and hopefully you've run into a few of them, I know they're out there, and if you can partner with them, then they can help you navigate through. I think that might be one avenue you want to take instead of going at the physician side of it and then having them, carry the message to IT and run into that roadblock.
I just want to add to that. You guys, actually, those are absolutely the correct answers. Slightly different, but not, I don't want to say I disagree in any way, because that's absolutely true. Having been an entrepreneur in the past and having to do a startup hospital, I kept a very wide open mind. But it is true, you run out of bandwidth. And even with a hospital, you have to, especially ours, a brand new one, and even existing ones, you have to strike that balance between innovation and actually providing safe, quality healthcare. And that's something I learned as a lesson early on, where I was like, oh yeah, start up a hospital, I want to do X, Y, and Z. I had to put a lot of quote-unquote candy back on the shelf. But to answer your question of, I mean, how to engage it, I think it's right, you know, make the partner of the CIO, and kind of as a segue, the role of the CIO is changing within healthcare, especially at the hospital level. Most CIOs used to, if there were CIOs, 5, 10, 15 years ago, they reported to the chief operating officer or the chief financial officer. They were considered an operational support rather than a business partner or a strategist or an innovator. And those roles are now evolving. One of the reasons I attacked innovation in my role is I made it a point with my boss, who's the CEO, and I think there's now still about 30% of CIOs that report to CEOs in hospital settings. That's changing because a lot of providers still see IT as a support role rather than an innovator role. And I think to answer your question, the industry isn't ready. Innovation is ready. Disruption in healthcare is there. You guys are here, thinking of all the cool ideas, and we're at Stanford, which is somewhat of an epicenter of innovation. But healthcare, and it's painful for me to say this, it is really a hesitant, a heavily regulated, focus on patient industry that's afraid to change, and change in a disruptive, dramatic way, and it's very political. 1 out of every 7 people work in healthcare in some form or another. And my opinion is, in many ways, it's a zero-sum game. So if you create a technology or a tool or even a process, and you come to us and say, hey, we could save you X money, well, that money is coming from someone that's providing care in some form in a certain way. So, you could go on for
That'll hit one of your
pause
collective
there.
bargaining agreements. Yeah.
So it's challenging.
Hi. It said in the program that we're going to talk a little bit, that this panel was going to talk a little bit about ransomware, which has been a big thing in the news among hospitals. Is it as big of a deal within the hospital as it seems to be from the outside? Because, for example, when MedStar in the DC area got hit a couple of months ago, it was a big story in that region for the better part of a week. And people are scared that, their data is going to be compromised.
Yeah.
Yes.
Yeah.
See, I got a yes out there.
Yeah.
It is actually the biggest threat to hospitals, providers, because a medical record is worth 10 times or 20 times than a credit card number. So ransomware is a big issue. It's a very big issue. My board chair, that's the thing they ask for an update on every board meeting. Where are you at? What's the progress? What's been done? I'll stop there.
Yeah, one of the biggest issues around the whole security environment, and ransomware is just a part of it, is that the problem we're running into now is not the 16-year-old kid who's trying to break into your house and gets in and, messes up your house or something, and then you call your insurance company and get it all fixed. And maybe you have some responsibility in that because you should have a home security system. Well, if a SEAL team lands on your house and wants to get into your home, I don't care what kind of security you have, that SEAL team's coming in. And that's what we're faced with, because we're faced with China, we're faced with Iran, we're faced with Russia. These are all nation-state attacks that are happening. Some of it's, ransomware around that. There may be some other, individuals around that. But a lot of this bad stuff is nation-state, and they're coming in. They're going to get in if they want to get in. So you can prevent all you want. You can, you do have to put in as much as you can from a technology and a policy, education, all those types of things. You've got to go as far as you can with that. But you also got to spend some time on what if it does happen. And it's not really what if, it's when that it will happen in your organization. So we spend a lot of time with mock types of role-playing around, we get hit with ransomware, trying to find out where it came from, how to minimize it, do we need to pay? Actually, with ransomware, that's one of the first things you need to get to very quickly is, should we just pay up? And so what is the questions you need to go down through to figure out whether that makes sense, or should you try to fight them? Because basically, that's all they want you to do is pay up. So, and you want your systems back. So you've got a kind of a mutually beneficial arrangement right there. So that's a thing where you need to spend your time on. Yes, you need to still, make it as bulletproof as possible. But in ransomware example, all you need is one person accessing their email account from home, clicking on the wrong thing, and off you go. And, how do you stop those things?
So my name is Kurtan. I work at Bayes Impact. It's a data science nonprofit, and we're currently working in healthcare to give tools to safety net hospitals. We're working with the Robert Wood Johnson Foundation to provide some of these tools at no cost. And my question is, as we've been doing a lot of research, we've realized there's a huge discrepancy between technology stacks of safety net hospitals who serve some of our most vulnerable patient populations and hospitals who aren't serving predominantly those populations based off of their geography. So my question is, how are we going to be able to help these communities that are so important if their hospitals aren't able to get them the tools that some of the best hospitals have? This would probably be
He's asking how you guys can help me. Is that a good interpretation? There you go.
No, that's, and I'll take another stab at this too, because I actually was in another board meeting earlier in the week, last week, and the question that had been raised, it was a moral ethical question that somebody raised and said, when you run some of these models and actually build in, based on race or region or where they live, is that the right way to go about doing things? And for all of us who are in data, actually think very hard and fast on what information we're pulling for what reason, and is it benefiting? So I bring that up in terms of what you're asking, right? Because the goal of healthcare is to make it affordable for everyone. And there has to be a give and take in everything we do, regardless of if it's, a for-profit or, a better hospital in a region that's making versus, a safety net hospital or something else. I think the goal that if we set up with the idea that, we're doing this such that it's the right outcome, right thing for the patient, but it's also affordable, it actually addresses all of those questions. That's my...
I'll take a slightly different tact. I agree with that, but I'd also add that I think while we would love that there was some way that we could, just hand it out, the reality is that that just isn't really sustainable. I think where we can sustain in the, especially the academic centers, is that we can take that technology, expend the effort to prove it, and get it to the point that it gets into everyday products. So rather than today, the predictive analytics is something you have to custom build. We saw a talk yesterday, had to do you have to have your own programmers, you have to build your own interfaces. That's not sustainable. A small community hospital is not going to be able to afford that. If it's something that comes in the EHR package that they purchase, and they just need to configure it, and then they get that, then suddenly they have those tools available. So what we need to be doing is pushing and pushing and pushing, making sure that those get to a point where it's almost standard of care. It just needs to be in the product.
Well, and I just want to say, UCLA in Southern California, especially for MLK, and I say especially for MLK, if any of you were old enough, or not even old enough, in 2007, the old MLK hospital closed, and it closed for various nefarious reasons, one being lack of quality of health care. In building the brand-new one, the UC system actually was an integral partner in helping launch with the state and the County of Los Angeles our hospital as a safety net, but as a national model hospital. So we do actually have support from the UC system and UCLA, in particular UCLA docs. And a lot of physicians are actually drawn to our area to support the mission of the hospital, to support the underserved. In fact, we work with the International Medical Graduate Program out of UCLA that takes foreign-born doctors who get retrained here, and their fees are forgiven if they spend a number of years working at the hospital in the area. So I think there's a lot of support. What does help is, and what I've helped set up a little bit at the hospital as we're launching now is getting vendors like yourselves in the time that we have to offer free licenses to pilot, because we're so brand new that we could try out a few things here and help the entrepreneurs who want to launch this, or companies who want to support it. So we're actually flipping it around. We're saying, try it out here, try it out with our safety net population. If it works for us, if it has this level of impact or this level of efficiency improvement, it could be something we could share to these guys, because it's really a partnership. We're all in the same boat, whether it's underserved or not. We're all trying to provide cost-effective healthcare. Because remember, even in the underserved now with ACA, someone's paying for it. We're all paying for it. Everyone is paying for it. So it's still very important work to do.
Super interesting comments. One thing I haven't heard any of you talk about, and I hear it a lot talking to a lot of other hospital systems, is what is your role in trying to improve the patient experience? Whether it's patient satisfaction, it's sort of the way that the facility is built, workflow, personalization services. We work with lots of big, like we're privileged to work with Stanford, but we're at Box, we work with a lot of other big academic medical centers or tertiary. And the number one thing, we're either talking to sort of a digital health officer or someone who's on that patient experience side. And I know with value-based care and all the surveying that's going on, it seems to be top of mind for a lot of folks, but I'm wondering what your roles, particularly given that you've been in this relaunch at MLK, where is that on your priority list, and what are you guys doing to help?
Well, I'll mention, but I'm sure my colleagues here have a lot to offer as well. We're small, so as a small leadership team, my role doesn't just involve technology or business or strategy. We round twice a week inside the hospital, and my leadership team, the directors and managers, we all round the hospital. So everyone is actually part of the patient care, patient experience, and patient care in the team. In fact, so much so that I really have a bias against, oh, we're the IT guys, or that's the IT department. In fact, since I got to start brand new, I'm just once in a lifetime opportunity, guys. I got to start brand new. I don't call it the IT department. I call it the health IT department, because we're so integrated, so part of the delivery of healthcare. All of our systems are so integrated that if the one system goes down, I mean, it's a burden, it affects a big portion of the hospital. So that hand in hand goes with, we're part of that care delivery. And so the role of the CIO, at least my role in a small hospital, is we're intimately involved with the rounding. We get our staff involved, and that's the new age of care. And with the clinicians and nurses, it's a really close, tight partnership. It's no longer a support role, it's a collaborative role, I think, more so.
Yeah, and we're attacking it. I mean, we're doing a lot of the same things that Sajid talked about, but from an analytics perspective, we're actually starting to mine geosocial data in a way to create patient profiles of individuals. So the goal would be, as an individual enters our organization, however that may happen, through an appointment or whatever that may be, is we start to mine that data right away and figure out things like, do they have an iPhone? Do they have a Samsung? Do they like to download apps? Do they like to text? Do they like email versus a phone call? All those things that can be done behind the scenes, all that data exists on you. How, you drive to work, the route you drive, all that data is out there, and there's firms that collect that and will, for a fee, sell it to you. So we're collecting a lot of that data. You can use it for marketing as well, from a standpoint of where to put certain clinics in your particular market, based on the population that lives in those areas. So we're looking at that as well, but mainly we want to build that patient profile. An example I'll give you is, you ever call an insurance company for a quote of any type of insurance, they'll start asking you questions, and while they're asking you questions, they're building a profile on you. They're already doing it. And you might be surprised to learn that the quote that you get is not based on what you've asked for and the different parts and pieces of that particular insurance program that you're looking at. It's based on your ability to pay. So you could have two people asking for the same thing. If one of them is making $250,000 a year and the other one's making $50,000 a year, they'll get two different quotes, okay? Now, that's not what we want to do in the healthcare side, certainly, but the data exists out there to be able to create that patient profile in such a way to actually help drive a good patient experience without that patient even knowing that it's happening, right? And that would be the best of both worlds. So we're not there yet, but the analytics is certainly out there. It's been out there in other industries, and it's time to start using that in healthcare now.
It's very interesting. I just want to comment on something slightly different that we're tackling. Everyone does the Press-Ganey scores and those sort of things. One particular group tends to get rated really poorly in there, and that's the pain management folks. And people with chronic pain just don't want to fill out a survey. They tend to not necessarily be very happy about having chronic pain. So we tried to tackle this working with one of our anesthesiologists a few years ago and created an open source project called Choir. And it's really looking at patient self-reported outcomes. And so we're actually trying to close that loop rather than just an occasional Press-Ganey out to somebody that they probably won't fill out, or if they do, they're angry when they fill it out. More timely and more regular interactions using computer adaptive testing, so they're not doing surveys of hundreds of questions, but maybe 10 or 15, and rating them on multiple axes, and then using that when they come back into clinic to help drive their care. So if they're not responding well to treatment, we're trying to then bend the treatment, and we're actually raising those scores in the pain management area.
Yeah, that's great. That's awesome.
So we probably have time for one more question.
One of you, I think it was Saeed, said that health information is worth 10 or 20 times credit card information. I find that fascinating. Could you explain that in more detail?
Yeah, very simply, a medical record contains social security number, where you live, your contact information, what drugs and other information you take. So when it's stolen, it can be used for not only identity theft, not just credit card fraud, but it can be used to leverage you in the future. So I've heard really crazy stories from our FBI meetings that we've had, and I'm sure Chuck and Todd have had others, but the value, the market, the black market value of that is that people will pay more. I think credit card information is pennies on per credit card, so they sell like 1 million credit cards for a certain amount. But a medical record, one alone can get you, I don't know, $8, $10, $15, something like that. But that's the value, because it has social security information and other identifying information in there.
Isn't it also that, like, the financial industry and the credit card industry has gotten so good at sort of security alerts and immediately, bank alerts and turning off your credit card, where, it's not only that there's just so much data in the medical record, it's just that, our breach notifications are like 48 to 2 weeks long, right, before we figure out what to do and how to notify and how to correct.
And then there's often not necessarily anything you can do to correct. And it's horribly difficult for somebody who may have suffered medical identity theft, where somebody has actually gone and seek care under their name to get any of that expunged from your record. It's very straightforward to get a new credit card number. I mean, we just call in and say, hey, I lost my credit card, and they FedEx you a new one. Yeah. They can't do that yet around medical identity theft. It's just, it's
Plus, they're really trying to put you, and not you certainly, and personally in a situation, but they're trying to find people that they can blackmail and get some really big money out of. So if you saw the breach that was in the government, it was all about people that had very high security clearances, and they were breached. So they had the list of people, and they had all their security clearances. And so then what they did was they breached Blue Cross, and they looked for the same group of people. Now they have their medical record. So now they're looking for these people who have high clearance in the government that may have some medical issues, right? And then next they breached was the Madison site. So now they're looking for somebody who has high security insurance, may have medical condition, but also was on that particular site, right? So now you're in the government. Now you can be blackmailed, basically, at that point. So that's how deep this is going, beyond even the electronic health record. But again, credit card, you're not going to be able to file a false tax return on somebody or anything like that. It's not as lucrative as it was in the past. So that's why people are doing it.
That's why I don't go to a doctor.
I don't. I'm a guy. We're guys.
I'd like to go ahead and thank Sajid, Chuck, Todd, and Dipti for just being a great panel for us this afternoon.
Thank you.